So thanks for inviting me to talk. So I was fortunate to present yesterday on behalf of colleagues from around the UK on a project we've been doing examining the impact of transplant in patients with NPM1-mutated AML. So it's well known that transplant benefits patients with bad AMLs, with adverse risk AML in first remission, and that in favourable risk AML it's not of benefit. And then patients with intermediate risk AML, it's really not clear what to do. NPM1-mutated AML is generally favourable, but is intermediate if there's a FLT3 mutation. And around the world, different people do different things when they're looking after these patients. So some people will transplant all NPM1-mutated patients who have a FLT3 mutation, and some clinicians will use what's called measurable residual disease, or MRD. So in the UK, we've shown that MRD in the blood after 2 cycles of chemotherapy really predicts who's going to do well or poorly with NPM1-mutated AML. So if there is detectable NPM1 in the blood, those patients do very poorly. Those were results from the AML17 study, and they were taken forward to the AML19 study, so that patients in the AML19 study who were MRD positive in the blood were recommended to have transplant, and those who were MRD negative were not recommended for transplant. And this was regardless of the baseline risk factors such as FLT3 or karyotype. So in this analysis, we combined the 2 studies to try and determine what the benefit of transplant was in these patients. We had 737 patients. They all had NPM1-mutated AML. They were in remission after 2 cycles of chemotherapy, and they all had a post-course 2 peripheral blood MRD sample. What we showed is that in the patients who were MRD positive in the blood after the 2 courses of chemotherapy, those who went on to have a transplant did much better than those who weren't. There was a significant survival advantage, both in overall and relapse-free survival, and a marked reduction in relapse. We looked to see whether there was any subgroups within which this was not true, and we looked at age, the white cell count, the cytogenetics, and all the different mutations, and we found that all groups benefited if they were MRD positive. Conversely, the patients who were MRD negative did not derive a survival advantage from going to transplant. So there was a reduction in relapse, and there was an improvement in relapse-free survival, but there was no overall survival advantage in those patients. We looked specifically at those patients with FLT3 mutations within this group, because many people would consider these to be mandatory for allogeneic transplant, regardless of the MRD. And we showed that even in this group, there was no statistically significant survival advantage to transplant in first remission. We looked again at all the other disease subgroups and again found there was no heterogeneity within subgroups. So all patients who were MRD negative did not derive a survival advantage from transplant. So we concluded from this analysis that the molecular MRD status after 2 cycles of induction chemotherapy could be used to best select patients for allogeneic transplant in first remission in NPM1-mutated AML, and that those who were MRD negative could safely defer transplant regardless of the other risk factors.